Welcome to Gastrointestinal Endoscopy Author Interview Series. I'm Dr. Glenn Eisen. I'm the Editor-in-Chief of GIE, and I'm going to be speaking with Dr. Ronnie Fass, who's a professor of medicine at the University of Arizona. The paper we'll be discussing is one that's been accepted for GIE. It is upper GI tract findings in patients with heartburn in whom proton pump inhibitor treatment failed versus those off anti-reflux therapy. Welcome, Dr. Fass.
Thank you.
So can you tell our readers a little bit about the impetus for this study? What made you think of doing this?
Well, I think the most important thing is the fact that in GI we see today primarily patients who failed PPI therapy as compared to the old days where you used to see patients who were never treated with any medications. So the question is, what do you do with these patients? Now, obviously, what we see in clinical practice is that the first thing that has been done in patients who failed PPI is upper endoscopy to see what kind of endoscopic abnormalities that they might have. And based on that, gastroenterologists hope to make a decision about patients' management. But we found out that there are no studies that truly looked in a systematic fashion what are the endoscopic and histologic findings of patients who failed PPI, for example, as compared to those who were never treated before. Because it's extremely important for us to know, does endoscopy, for example, alter management in this patient? Do we get any new information that can help us how to manage these patients?
Right, and we suppose that we do because most of the endoscopy guidelines recommend one of the main indications for doing an endoscopy is PPI failure.
That's correct. And that also came out in an ASGE guidelines in gastroesophageal refluxes that clearly recommended an upper endoscopy in patients with persistent heartburn.
Right. So it's interesting to me that for your paper you define PPI failure as once daily treatment rather than twice daily. Can you explain the rationale behind that?
Well, it's true that the literature has pushed to the concept that twice a day that failure of 2 PPIs per day is considered to be PPI failure. But there are several issues with that. First of all, when you look at pharmacological indications for gastroesophageal reflux disease, there is none for twice a day PPI. They're all once a day. And so all drug development in the future will be for once a day PPI. It will not happen for twice a day PPI. In addition, the data truly show that if you fail PPI once a day, there is a good chance you will also fail PPI twice a day. So when you fail PPI once a day, you're kind of entering the PPI failure club.
Okay. It's interesting to me that you were actually able to find patients who were naive to therapy for reflux. Where did you find these rare individuals?
Well, we still have some of these patients. I have to admit, they're not as common as they used to be, but we try really to reach out to these patients, not only within our hospital, but also outside. So bring them on board, patients who were not treated on a regular basis. Also, we have a large number of patients that don't take PPIs on a regular basis.
Okay. And what did you find in this study? What were the outcomes comparing the two groups?
I think the most important thing is the fact that when we looked at patients who failed PPI as compared to those who as compared to those who were not treated with PPI, well, first of all, the endoscopic findings were much less common in this group. If there were any endoscopic findings, they were primarily consistent with gastroesophageal reflux disease. But surprisingly, erosive esophagitis was much less common in patients who failed PPI once a day, as maybe one would expect, as compared to those who were never treated with a PPI. And the erosive esophagitis that we found were almost exclusively very low grading, grade A and B. We did find the same prevalence rate of Barrett's esophagus. Another surprising finding from this study was the fact that only one patient within the failure group had eosinophilic esophagitis, something that has been suggested by some authority to be a common cause for PPI failure.
Right. Do you think that's explained by the demographics of your study?
That has been suggested, and was one of the critique of my paper, that maybe because it was primarily a veteran population that we didn't see many patients with eosinophilic esophagitis. But at the same time, this was a male-enriched population.
Right. And the one patient that was found with erosive esophagitis, was it evident on endoscopy that they had the typical furrowing, or were you taking random biopsies in all these patients to look for it?
Yeah, well, we did take biopsies in all these patients regardless of what anatomical findings they have, but in this specific patient, that's correct. the patient also had anatomical abnormalities consistent with the eosinophilic esophagitis.
So what is the practitioner to do with this information?
But I think we have to understand, especially as gastroenterologists, the value of upper endoscopy in patients who failed PPI and what we're getting. Now, as you mentioned, in practice, many of these patients will be scoped after twice a day PPI, which suggests that even in this patient population, we probably see even less endoscopic findings. So we have to understand that maybe endoscopy has very little value in evaluating patients who failed PPI. And the other thing that came out from this study is the fact that eosinophilic esophagitis, at least from this type of work, and I agree that we need more studies, was not a major cause for PPI failure.
Okay. This isn't necessarily part of your study, but as an expert in this field, how do you manage these patients who fail PPI therapy, have either a normal endoscopy or minimal esophagitis, yet are still symptomatic?
Yeah, that's a very good question. So what is the data there? So you have, in this patient who failed PPI once a day, there is some data that at least a small number may respond to more than PPI once a day. That might be one option. Another option to switch to another PPI, there is some data. You may not get full resolution of symptoms in most of these patients. So what do you do next? Well, the way I work in my practice is I have an access to impedance plus pH, and I try to stratify these patients based on that.
On both impedance and pH?
Yes.
Okay.
So it's a combination of impedance and pH sensor. And that allows me to find patients that have what we call non-acidic reflux, which will be about 35%, residual reflux about 11%, and then a little bit more than 50% functional heartburn. And then I tailor my therapy to each group. So the non-acidic reflux, I'll try to give them some TLESR reducers. For residual reflux, I may add an H2 blockers, make sure that they are compliant. And those that have functional heartburn, I'll probably look at visceral analgesics.
Okay, so most practitioners don't have impedance at this point, and it's not routinely available or really all that well validated. If you were in a typical practice, would the next step be give them a second PPI and try that for X number of weeks, or would you go to a pH probe to see if they had an acid-sensitive esophagus or possibly didn't even have reflux at all?
Absolutely, and I agree with you, most of the people don't have an access to impedance. So this is what I would do. If they fail PPI once a day, you have the two options, either to double dose or switch to another PPI. If the patients are still symptomatic, which will be the case in most of them, then I try to tailor treatment based on what is the predominant symptom of these patients. If they have primarily regurgitation, symptoms that are consistent with more volume reflux, this is where I would position a TLESR reducer and see what happened. If they have primarily heartburn and they don't show any evidence of volume reflux, you can start maybe with an H2 blockers to pick up those with residual acid reflux, and if it's not working, I will probably move to hypersensitivity and treat with visceral analgesics.
Okay, that's Dr. Fass. All of those points are very helpful for our audience. Thank you very much.
Thank you.